Move it down here and be close to you. You can feel me. You can feel me all the way up. I hear you. Yeah, and unfortunately, you'll hear me for decades to come. Okay, before I forget, something Dr. Williams has said to me resonated with me, and I wanted to bring it to you guys and say it to you. And if I don't say it right away, I'll forget about it later because it has nothing to do with patient care. She did a presentation with some nursing students and respiratory care students and other students about social media. And we were talking about that. And one of the things that, as we were talking, kind of came up with an idea. It wouldn't be a bad idea for you guys to make a LinkedIn account if you haven't already done that. And one of the advantages of doing that is all those things you wish you could put on your resume, but it's going to get too long, you could put in your profile on your LinkedIn account. And then something else you could do is you could go to whatever hospitals you're interested in. Most of them have some form of LinkedIn account, or go and look at those sites and see if you can find anybody that maybe was an MSU graduate. And then you would have a contact. You could link in with their LinkedIn account. And then that would maybe give you a little entry into that hospital. Yeah, wouldn't be a bad idea, would it? Use the social media for good rather than evil. Yeah. So, yeah, I was thinking that wouldn't be a bad idea at all to find people that way, and then you would have some contact there. Maybe that person maybe could give you, because that's what it's for, is networking, give you some ideas of how to get a job in the areas that you really want to work. So I wouldn't say that before I got out of here today, because I know it won't stay in my head for very long. Okay, anything that we need to discuss before we move on? Okay, well, we've got a case today. I think you'll like this case. It's an interesting one. So our patient's 59 years old, and he presents to the emergency department with complaints of severe crushing chest pain. And so we're going to implement the AHRQ, National Guideline Clearinghouse, American Heart Association guidelines for acute coronary syndrome and myocardial infarction. So step one in those guidelines is a symptom history. So we need to be thinking about, with what he's given us, he comes in, he says he's got the severe crushing pain to his chest. We need to think about what other symptoms, what other history we might need from this patient. Because immediately, probably what's running through your head is this patient dealing with a myocardial infarction? Or at least that should be running through your head. The guidelines also say to immediately do a 12-lead EKG. So you will note if you've done any emergency department clinicals that these days the triage rooms have EKGs, and usually some kind of stretcher or something, you can lay that person down and do that 12-lead right then and there without having to take them somewhere else. And then to do EKG recordings, and this would be like a cardiac monitor. To go ahead and put the cardiac monitor on that patient. To look for risk factors for having a myocardial infarction. And then the measurement of cardiac biomarkers, that one it says is kind of optional. To go ahead and do that measurement if you think you should. If you don't think you should, you don't really have to. But that one is could be done right away, because most ERs these days have some sort of fast track cardiac biomarker analysis machine right there. And then the chest X-ray and echocardiogram is indicated. But certainly these first four, that as this person comes in, we want to take a symptom history, a 12-lead EKG, serial, put a cardiac monitor on them, and do a risk factor assessment. So these are the symptoms and the history that we get from this patient. We know he has a history of asthma and GERD. He smokes 2 packs a day for 40 years. He drinks 1 to 2 drinks per day. And he's 6 foot and 206 pounds. He has chest pain that's crushing mid-sternal, so he's able to point to us and tell us it's mid-sternal, and it's radiating up to the left jaw area. Began 90 minutes ago, and he is diaphoretic. And then these are his vital signs, which are not horrible. Any one of us might have these vital signs on a given day, so they're not scary, but there are some things in his presentation that are scary. The fact that his pain is specifically mid-sternal. He's not saying that it's in a broad region, it's right here in the mid-sternal. Indicates that probably is more likely to be cardiac. When you're assessing patients who come in and say they have chest pain, the problem that you're really going to have, what you're really going to have to look at is this pain, is it coming from the respiratory system, the cardiovascular system, or the GI system? The respiratory one's usually pretty easy to either rule in or rule out. You ask them if that pain gets worse when they take a deep breath, and they say yes, it's much more likely to be respiratory, especially if they can pinpoint where that pain is. Yes, it hurts right here when I take a deep breath, type of thing. Then that's usually not cardiac, and so you can kind of then go down the path with respiratory. Where it becomes really difficult is GI and cardiac. Those are the ones that are very, very difficult to differentiate. So he has some things here that makes it sound more cardiac, and that is because it is crushing and it's mid-sternal. When they say that it's GI, it's usually in this region of the abdomen. Now, sometimes it's hard for them to tell you because they can't really tell if it's here radiating down or here radiating up. So it's mid-epigastric when it's GI, but sometimes when that pain is cardiac, or sometimes when it's GI, it's hard to know if that pain is actually radiating down to that area or if it's in that area radiating up. Because things like pancreatitis and cholecystitis, those will radiate up, and you can't really tell. It's so diffuse, it's hard to really know. And sometimes with myocardial infarctions, this pain is not so distinctive that they say crushing mid-sternal. It's like I've got this chest pain, it's in this region somewhere, but I can't really tell if it started here and went up or here and went down. And so that can make it very difficult with GI. The other thing that tells me that this is more likely cardiac is he tells me it's radiating to the left jaw area. That's a cardiac radiation pattern. Usually when it's GI, if it's going to radiate straight to the back, or it's going to go up to the right shoulder. Now, cardiac pain, unfortunately, can go to the back, it can go to the shoulder, it can go to the jaw, it can go to the arm, it can go in a lot of different directions. But those two things, his crushing mid-sternal and radiates to the left jaw, is making me lean towards that this is a cardiac problem, more so than a GI problem. So once we think it is a cardiac problem, and then diaphoresis usually tells you it's a bad thing. When they come in, unless they've just been out in the sun kind of thing, they come in and they're diaphoretic, that usually means the body is not dealing well with whatever insult has happened to it. But it's not going to be specific as a cardiac, because it could be a stroke, or it could be pneumonia, or it could be pancreatitis. They'll get very diaphoretic with that as well. But that's usually a bad thing. You look at that and you say, I don't like that, and I better watch this patient very closely. So once we determined that we thought this was a cardiac, we immediately did, as I said we were going to do, this. We did the 12-lead EKG, and it showed ST elevations in leads 1 through 4. And so that gave us the diagnosis of acute anterior MI. Remember I showed you the last time we were together how you would have the reciprocal changes and looking for those ST elevations in at least 2 leads is what we were looking for, and it was there, and this patient's having acute anterior MI. So in this case, we suspected cardiac, and it was cardiac. Step 2, we're going to apply supplemental oxygen. This again, anything that says step came from those guidelines. I took it straight from those guidelines. And those guidelines are available online. There's several pages, so I didn't print them all off or anything. But I put them on these slides, I put them by step. So supplemental oxygen, we're going to give nitrate therapy. And the preferred nitrate therapy today is that you have them stick out their tongue and you spray the nitroglycerin onto their tongue. That's what we prefer to do, but it doesn't have to be that way. We still do sublingual, but if you have the spray, that's the preferred. It absorbs a little faster. Aspirin, if they've not already taken it. And what we typically give here is 4 chewable baby aspirins. The chewable ones work better. They absorb faster. So we usually give 4 chewable. Well, each one of those chewables is 81 milligrams. So we give them 4 chewable baby aspirins. We tell them to chew it, not swallow it. And then morphine if the pain is not relieved. This is what the guideline says. Now, every single NCLEX book you read is going to say MONA. It's going to say morphine, oxygen, nitrate therapy, and aspirin. But this is the actual guideline. It's this order here. And frankly, this is what I've seen. I have not seen us give morphine first. And the reason, a lot of the reason for that is morphine, you would have to have a protocol in place to give it. And it takes you have to go into the Pyxis and whatever, whereas a lot of times aspirin and even the nitrate's just setting out for ready use. So in my experience, we do it this direction. This is literally what the guideline says. We may also give some diazepam for anxiety, and we may, the provider may come in and prescribe, I can't say this with clopidogrel, something like that. This is like Plavix. Give that. And low molecular weight heparin. I should have put heparin out there. I don't know why I didn't. Probably somebody knew about me about it. So low molecular weight heparin. I get very easily sidetracked from stuff like this. So these 2 definitely are going to be added to that regimen. Diazepam, yes or no, depends on how anxious they are, but definitely some form of an antiplatelet and the low molecular weight heparin. Oops, didn't type anything, did I? I have to enable editing. Let's put that. Also, for some, we'll give this glycoprotein 2B3A receptor blocker. It's another antiplatelet medication. Metoprolol may be given. Now, if we give metoprolol, why do you think we're going to give it? Decrease what? Decrease the workload of the heart, you're right. It decreases the circulating catecholamines associated with stress. And that stress puts stress on the heart. If you think about your fight or flight response, one of the first things that happens is the heart rate goes up, right? If I were to come in here after your mother baby test and say, oh, I moved our test to today, we would have some released catecholamines. And the first thing that would happen is your heart rate would go up because it's going to try to circulate this blood more rapidly so you can run out of here. So any kind of stress to the body will release these catecholamines. Well, if your heart's having some problems with oxygenation, you don't really want to put it under any stress. And that's what the metoprolol is for, not to lower blood pressure. Although if the blood pressure is high, that's a benefit. But if he's already on another drug that he's getting that's going to help lower that blood pressure, you may know which one it is? The nitrate. The nitrate. Now he has a nice solid blood pressure right now. We're not too concerned with those nitrates or that metoprolol. We can give both of those and everything ought to be just fine. But not all patients who are having an MI come in with normal blood pressure. Some come in with low, some come in with very high, depending on what other conditions they might have had. But we generally do give the metoprolol, that's the beta blocker, most commonly given during this time frame. And then we'll oftentimes give a statin. All right, and then the step three is to get them to the cath lab. Step 3 is to get them to the cath lab. We are continuously trying to get them from discovery of the chest pain to the cath lab in the shortest amount of time. Step 3 is get them to a cath lab. We are going to get that down to the shortest amount of time. The standard says within 90 minutes of calling EMS, of them calling the EMS or walking into the ER into the cath lab within 90 minutes. I can't imagine any ER that is working with myocardial infarction being satisfied with a 90-minute delay. You're going to be real proud if you can say things like 20 minutes. That's what they're looking for. They want to know as soon as they know that that patient has chest pain, that they're in that cath lab that quick. Now they could do thrombolytic type of therapies, and there's a whole nother protocol for that. They could do the thrombolytics and try to break up the clot first. Not typically what's going to happen. That would more likely happen if there wasn't a cath lab available. In today's current market, in any kind of town with any kind of size, there's probably a cath lab readily available, and we're going to try to get them in that cath lab, like I say, within 20 minutes of the fact that they've been presented with chest pain. So getting them to the cath lab is the next step. So once he goes to the cath lab, they'll take him in, they'll put the catheter in, they find the blockage, and they go ahead and put a stent in at that time, just to remove that blockage and leave that vessel open. Then he's going to be admitted into some cardiac care unit. And now we've got post-operative care for post-procedure care, probably be a better term for it. We've got post-procedure care we have to deal with. And that post-procedure care is going to focus on performing perfusion assessments and making sure that this patient's extremity and heart are well perfused. You've got to worry about the extremity where they put the cath and then the heart itself. So you're going to do some close observation assessments that focus on perfusion. So we're certainly going to do things like cardiac monitoring. We're going to do things like look at the site to make sure it's not hemorrhaging. We're going to do things like assess the distal pulses to make sure there's perfusion there, and the cath refill and the CMTS. All of those things that are perfusion assessment. If I see a perfusion assessment to you, you ought to be able to say back to me, CMTS, pulses, cath refill, level of consciousness, and urinary output. You ought to know that. That's a perfusion assessment. They're going to have to keep that extremity straight, depending on the cath lab and whatever product they use, depending on how much time they have to keep that leg straight. Usually 4 to 6 hours, but there's some places that are down to 2, and there's other places that are still doing the 12. So, but it's usually 4 to 6 hours. And that's our post-operative care. The patient was admitted onto the unit. His lipid profiles, all of his lipid profiles were negative, so all the lab work they did, the CBC, the survey 8, the urinalysis, They did a thyroid on him, they did all sorts of things. They were negative, but his lipid profile showed hyperlipidemia. We need a list of his home meds, and these are his home meds. So these were the ones he took at home. So, are there any problems with these meds? Okay. Post-procedure, he is receiving, I have no idea how to say that yet, but it's one of those glycoprotein 2B, 3A inhibitors. And he's just going to receive that intravenously for 12 hours. But he requires risk assessment for a thromboembolism because remember, they went into that groin and they did this cardiac catheterization. And he's already been on these drugs for antiplatelet aggregates, so they must have thought he had some antiplatelet concerns. He's on a statin drug, which tells me that they know he's got hyperlipidemia. These are all things he was on at home. And so he's now a required risk assessment for thromboembolism. 6 hours after the cardiac cath, he reports breathlessness, anxiety, and diaphoresis. These are now his vital signs. His urine output is within normal limits. So now we've had a change in condition. He's not bleeding. If you go to his puncture site, there is no blood there, so or no hematoma. He's not bleeding. So we have to decide, are we going to just continue to monitor? Are we going to do some form of a nursing intervention and reevaluate to see if it improved the situation? Or are we going to notify the provider? You're going to continue to monitor? I'm sorry? You're going to notify the provider? Why? He's got something else going on? I can't understand what you're saying.
Yeah, I mean, like, fishing to have like that.
You think he might have a PE or something like that. And that's exactly what we do. We look at these symptoms and say, is there a complication of a myocardial infarction or the cardiac cath that we just did? Is there a complication that might cause this change in condition? And if you say yes, there is a complication and maybe that patient is experiencing that, then you have to decide, is it something that I need to intervene now? Is there something I can do to make it better? Is it not that significant of a change that I can just continue to monitor? But he's had some pretty significant changes. Now, if we do the Muse, how many points does he get? Does he get one for heart rate? No. Systolic blood pressure 115, no. But his respiratory rate gets us 2, right? His urine output's normal. His central nervous system, he's awake and responding, but he's got a little anxiousness, doesn't he? So you might kind of give him something for that, a point for that, I don't know, but we don't have to. And then oxygen saturation is 94%, so he gets a point. So now we have 3 points, right? Are you putting oxygen on this patient at this point? So now you're giving him oxygen therapy, he's got 4 points. He's got 4 points, he's right there, and there is no decision to it, you just call. So at the least, I think I would either do some nursing intervention you think might make this better, or I would call the provider, one or the other. If you can think of a nursing intervention, maybe the oxygen. Then go back, evaluate that, and see if it makes any difference. That would be fine. That would be absolutely fine. One of the things we can't really do with him is we can't elevate the head of the bed, can we? Because he's, unless they said 6 hours was the limit. and then we could. But if he's still having to keep that leg straight, then elevating the head of the bed is not an option that we have. But we certainly do have the option for oxygen therapy, so perhaps we put that on there. Now tell me, when you put that oxygen on him, how much oxygen are you gonna give him and how is he gonna have it delivered? I'm sorry? 2 liters by nasal cannula? What if, and then how do you know if it's effective?
The O2 sat will go up.
The O2 sat goes up and he becomes less breathless, less anxious, and less diaphoretic. What if you put the 2 liters on and he doesn't get any better?
Increase it.
You might put it up a little bit, yeah. How high would you be willing to go?
6.
6 with a nasal cannula?
No.
Not
With
me.
the mask.
Do not put 6 liters of oxygen with a nasal cannula on me if you don't mind, please. That's gonna burn. That's gonna burn. Yeah, that's gonna be a little bit too much. You can put that on, but at least change it to a face mask and get it up there more like 10. Or you could maybe put a partial non-rebreather mask on and put it up to about 10. If you have to put a partial non-rebreather or a non-rebreather mask on, you've got a serious condition, go ahead and put it on, but you best be calling some doctor. They're needing that much oxygen to be able to maintain what you want them to maintain. You need to call the doctor. Okay? So they do a chest x-ray and he has pulmonary edema. So what's the treatment for pulmonary edema? Positioning. By this point, we ought to be in a place where we could position. So what position would you put this patient in? Don't know? High Fowler's, yes. Oxygen supplementation, and now, if he's got pulmonary edema, we may need to put a little bit more oxygen on than 2 liters per minute. There's definitely maybe a patient that we're putting a face mask on or putting a non-rebreather or partial non-rebreather mask on. Morphine, perhaps, especially if he's got chest pain associated with it. Definitely a loop diuretic. And the one that was ordered for him is furosemide 40 milligrams IV. So now you're going to give this furosemide 40 milligrams IV. What do you have to know to give it to this patient? The urine output was normal, remember? What else do you have to know? His potassium level was normal, remember? All of his SMA-8s, everything was normal. Anything else? I'm sorry? Weight, we got that. It was 206 maybe. You're missing something major. I'm sorry? He has no renal disorders. His urine output, his urinalysis was all normal. His BU and creatinine was all normal. They did all that. They did the urinalysis, the CBC, the SMA-8. They did a thyroid check. They did the lipid panel, the liver panels. Everything was normal except for his lipids. They did that when he was through the ER. Everything was normal except for the lipids. So you got to give this loop diuretic. What else you need to know? He has that glycoprotein inhibitor infusing. Interactions, okay. So what are you going to do? You got to get this furosemide into this patient. Tell me what you're doing to do so. Does he have another IV site? And if he doesn't, what are you going to do? We're going to put in a saline lock. What size angiocath are you going to use? A 20? Why a 20? Why not a 22? Why not an 18? A 22 is too small to give furosemide? That'll work just fine for furosemide. How do you determine which size angiocath you're going to give?
Depending on what you're giving.
What you're going to give through it. And you use a larger one for what?
Viscous.
More viscous or really large volume fast. So you think you're going to give a large volume fast to this guy? No, so we can use a smaller one. Now to tell me why not a 22, why a 20? Just your preference. Okay, what would be the patient's preference?
Smaller.
The smallest you can use. Yeah, there's no reason we can put 22 in for this. It's not likely we're gonna give blood. This doesn't seem to be a bleeding problem. This is a respiratory problem. It's got pulmonary edema. It's a heart and respiratory problem. Not likely gonna give blood. We're not likely gonna give him a big bolus of fluids. His problem is he's got too much fluids. We're trying to get him off of it. So 22 gauge will work just fine. All right, so you finally got the AG cap in place. That took a little time. Now then, you can still gotta give the drug. What else we gotta know to give this drug? How fast to push it. You gotta know how fast to push it. And whether or not it needs to be, it doesn't need to be diluted, but whether or not it needs to be diluted. Since we're doing it through a saline lock, we don't have to worry about compatibility, but we do have to worry about dilution and rate of infusion to get this in. And then once we give it, we've got to worry about therapeutic and adverse effects. So what are the therapeutic effects we're hoping for? Diuresis, just urine output, is that the only thing you care about? Because why are they giving it to him? Because he doesn't have enough urine out?
No.
Because he's not breathing well. So we got to improve that breathing, that's exactly right. Now tell me what adverse effects we're going to be looking for. Transient hearing loss will come if you give it too fast. Have you ever seen it? I have. I've seen where the nurse gave the furosemide too fast to the patient. Totally deaf. Totally deaf. Luckily, it is transient. But you got to wait for it to wear off. Yeah. I have seen it. Freak the nurse and the patient out. And the family member even worse. Yeah, as you can well imagine. So what else are we going to look for adverse effect? Hypotension. We're already giving him a nitrate. We've already given him metoprolol. We're already now giving him furosemide. We're giving him a lot of drugs on a blood pressure that was not that high to start out with. At least it was a little high. So maybe we don't even bother out his blood pressure. But that is the big one you're going to have to worry about. Is that hypotension. Patient was sent home 72 hours after admission. These were the medication that he was sent home on. They didn't really make any changes except what? They increased the aspirin. That's the only thing that they really did change. Patient returns 2 weeks later with complaints of tenderness, edema, and redness to the right proximal leg, not to the distal leg, but up close to the groin area. They get a diagnostic. His D-dimer was greater than 5,000. The Doppler showed a thrombus to the proximal leg. He was diagnosed with deep vein thrombosis. Well, this just gets better and better, doesn't it? The treatment, this also, I should have wrote this down. This came from a guidelines too, another AHRQ guidelines on deep vein thrombosis. Bed rest with bathroom privileges. Doesn't specifically say heparin and warfarin, but it does say anticoagulant therapy. It gives them lots of options. And I would say that the most common options that they're doing right now are low molecular weight heparin twice a day. Although they're also using things like Eliquis or, what's the other one that they use a lot? It'll come to me in a minute. I'm sorry? Xarelto. Mm-hmm. They're using those as well. So it gives them the option in that in those guidelines as to which anticoagulant therapy they use. And that's much more common these days than using the heparin and the warfarin. So this order here, heparin 5,000 units IV bolus and continuous infusion of 1,200 units per hour. What are they wanting us to do? What's that provider wanting us to do? Give a loading dose and then the maintenance dose. So, Mackenzie, when you gave that loading dose, how long would you wait before you started the maintenance dose? You want to call a friend? Is there anybody in this class that you think might answer that question for you? Look at their little faces. Beautiful, just beautiful. Anybody know how quickly we need to give this? You give it when? That night? So what if this is 2 o'clock in the afternoon? You're giving the bolus at 2 and then the continuous infusion at night? How many want to do that? Well, when do you want to give it? Why do you want to start it right after? Because you're going to, what's the whole purpose of a loading dose? To get it there quickly. And how do we know if something is therapeutic without a lab value? If you don't have a lab value, admit we don't have a lab value. But if you don't have a lab value, how do you kind of know whether it's at the therapeutic range? What do you use? Am I scaring you to death at all the non-thinking that you've been doing? Like, oh my God, how many patients have I killed? Luckily, the hospital just buried the body. Think about it. How do you know when a drug is therapeutic if you don't go get a lab value for it? Well, they won't know any more than you do, huh? No? You don't even have to assess your patient. You don't have to go in the room. You can send the nurse's patient in. And what are you looking for in that drug book? The peak. That's when it's most therapeutic, isn't it? You look in the drug book at the peak time. So you're going to look to see when it's going to start, when it's going to peak, and then how long it's going to last, aren't you? If you look up heparin, it's going to say you got 15 minutes of peak. 15 minutes after you give it. It's quick. Unfortunately, it doesn't last very long. So that tells me that I've got to give that drug, that continuous, immediately, because I'm pushing that loading dose. That's what loading doses are for. Let's get it up to therapeutic quick. I'm pushing that up in the therapeutic range. I've got to give the other one quickly thereafter, or it's going to be non-therapeutic. And then now the slower dosing is going to take longer to get it back to therapeutic. And what's this heparin going to do for this patient? Going to decrease clotting. So how does it work on deep vein thrombosis? It prevents other cells from clotting on top of the clot that's already there. Does nothing to the clot that's already there. It just prevents other cells that are circulating around, those little blood cells that he has. Now, hopefully his are not all that sticky because he's on Plavix, but those cells from clotting on top of these cells. He was on Plavix when he got this deep vein thrombosis, wasn't he? And the aspirin got pumped up, and he still got this deep vein thrombosis. He still got it. So that's all it's going to do. Then the body has to absorb that clot that's in there. So we're going to have to give that. Now, why are they ordering the warfarin on top of that? So they go home on the warfarin, and it takes a long time for it to get therapeutic and for you to manage it at a therapeutic. That's the problem with warfarin. Warfarin would be a perfect drug for anticoagulation if it didn't go up and down in its therapeutic range. And what you could take the same dose every day, and tomorrow it may no longer be therapeutic. It's nice because there's an antidote. We wouldn't need Eliquis and Xarelto and all those other ones if it wasn't for the fact that warfarin doesn't stay within therapeutic range. So we'll give it now with that heparin and let the warfarin, we start to manage whatever dose he's going to get, and then we can get rid of that heparin. So if we're going to give that heparin dose, here's my vial of heparin. What's the concentration of that heparin for those of you who are sitting up front and can see it? 1,000 units per milliliter. And what's the total volume in that vial? 30 milliliters. Those of you who missed what's the total volume in the dosage calculation quiz on Monday, were you just like shaking your head when you got it and went, did I really miss that? Only, I think it was 75% of you got that question right, and I just chuckled. And man, you give them an easy one, they still miss it. Now, the total volume on this one is 30 milliliters. So if we're gonna give this 5,000 units, how much of this are we gonna give? 5 milliliters? Yeah, we're gonna give 5 milliliters. Where are you giving it? So where are you giving it? You're gonna give IV in the side of the abdomen. No, probably not. Alice, quit making your voice throw in and having a lot say those crazy things. You know she didn't say that. I came from Alice the whole time. She's just tricking us. No, we're gonna give this an IV, but which IV? That's really the question. I'm sorry? In the saline lock, are you gonna give it the saline lock? Well, remember, we started the saline lock for the furosemide. Now we've got that antiplatelet drug running. And then we got a saline lock. Oh, that was 2 weeks ago, that's right. So now we have to put another saline lock. But is that what we're gonna give this and this infusion?
No.
What are we gonna do here? What do you think you would do here?
What's the question?
You put saline lock and you're gonna give this bolus, you're gonna connect this infusion to that saline lock? Is that gonna be his primary infusion? What are you gonna do? Flush it? Now, why would you have to flush between heparin if you're gonna hang heparin? We can put this on the saline lock. We can put a saline lock in, give the heparin, and put the continuous infusion. But what we've essentially done is now that line can only be used for heparin, right?
Yes.
So if you're gonna have to give anything else or do anything else IV, you're gonna have to have another line because heparin needs to be dedicated. That's what we call that. Remember when we were giving the antiplatelet drug, the glycoprotein drug, inhibitor drug? That one was going on a dedicated line. I mean, it's just that one drug was all that's going through it. Now we've got the patient back and we're giving him this drug and it's gonna be in a dedicated line. So if you need an IV site for anything else, you're gonna have to put another saline lock in it. Or if they get somebody to put in a PICC line with multiple lumens. Okay, so we're going to start this. Now then, what rate are we going to infuse that heparin? Here's the order. What rate? I'm sorry? Here's the order. And here's the drug. It's 1.2. It's 1.2. It's not. It's 12. 12 watts. Milliliters per hour. So we're going to go up to this pump and we're going to hit the rate button and we're going to put in 12. When we hit the volume to be infused button, what number are we putting in? 250. So we're telling that pump to take this whole bag of 250 milliliters of heparin sodium in normal saline, take the whole bag, but infuse it at 12 milliliters per hour. That's what we're telling you. So at some time later, we give a PT and a PT and a PTT. The PTT is used to monitor what? Heparin. It's used to monitor heparin. So let's drop down and look at the PTT. Here is the PTT. Are we happy? No, why not? Not in therapeutic range. What if the PTT was 27? Would you be happy? If the PTT was 27, would you be happy? That's the question on the table. How many are going to say yes? Raise your hand. The PTT was 27. How many are happy? Raise your hand. You got to vote one way or the other. All right, if the PPP was 27, how many of you are not happy? This one's fixing her head. May, I'm gonna let you take care of me. I'm gonna let May take care of you, the rest of you know so much. We're not gonna be happy with the 27 because what's the drug supposed to do? It's supposed to make you bleed easier than you would normally. So you don't want the PPP in a normal range. This is for normal people, people not getting heparin. So now we've got to create a new range for the people who are getting heparin. So how do we do that? 1.5 and 2.5 times the control. So create a range for me. What is 1.5 times 25 and 2.5 times 25? $37.5 to $62.5. 37.5, 62.5 is the new therapeutic for this patient. So new therapeutic for this patient. So then we would look and we still would have it's too low. So what needs to happen? We increase it. Now in most facilities today, they have some sort of sliding scale for heparin infusions. They've got them written out. Most of them are weight-based and you have to fill it in. But they've got them written out for what the sliding scale is going to be. But that's essentially what's happening, is they're getting 1.5 to 2.5 times this number to come up with a new therapeutic range for that patient. You do not want it to be in the therapeutic range that's printed on the slip because that's for people who are not on heparin. You want heparin to make them bleed easier. It's a therapeutic effect. Now by that same logic, let's go up and look at the INR. Is that INR satisfactory? No, what should the INR be? 2 to 3, because we're using the warfarin to treat DVT, aren't we? So you find out whatever condition you have, we're using it to treatment of DVT. We want that INR to be 2 to 3, and it is 1. This doesn't matter, but this whole normal thing, that's for people not receiving warfarin. That's not for people who are receiving warfarin. This is the stuff for people receiving warfarin. So we just match it up and that's not high enough. So this provider needs to be called and there needs to be a change in therapy, right? Now a lot of times that change is already written in a sliding scale point. It tells you what to bump it up to and when to check it again next. I'm sure you saw some of those in Ms. Diskel's dosage calculation quizzes. I know she asked those. All right, so later on the patient complains again of anxiety, chest pain, cough, and breathlessness. We do an assessment, we find bilateral crackles and wheezing, distended neck veins, chest pain increases with inspiration. He has shallow respirations, peak frothy sputum, and these are his vital signs. Well, now what? What do we think's going on? PE, a pulmonary embolus. That's the signs and symptoms of a pulmonary embolus, isn't it? So now we think he has a pulmonary embolus, so what are we going to do? Nothing? Call the doctor. And he does a CAT scan, and guess what this patient had? Pulmonary embolus. Well, darn. This poor guy. Wait till you find out why all this happened to him. So what all went wrong? Well, that's the next step I want to know is what all went wrong. We're going to start back right here. Actually, we start back with his home meds. They're pretty much the same thing. We'll start back with his home meds. There's a problem in this home meds. Anybody see it? Nope. Don't see it. So how are you gonna find it if you don't see it? You're gonna have to look up those darn meds. Don't you hate it when you have to use an external hard drive to your brain? Until you carry all this stuff in the brain, you gotta use the external brain. That's the problem with those meds. Luckily, he doesn't have 25 minutes. Are you happy about that? If it was me, I wouldn't start with the PRN because he doesn't take that very often, so it's probably not what caused his problem. I think quick on my feet like that. Like, ooh, that can't be the priority. Statin drug, what about it? It causes blood vessel problems. Okay, good. There's another problem. What about, I'm sorry?
Aspirin.
Aspirin and Plavix. The aspirin with the Plavix can kind of decrease the effect of which one? The aspirin. Okay, there's still another problem. The, you can't use what? You can't use the O one and the C one. There you go. That's how I say those drugs too. You can't use the O one and the C one together. If you do, you decrease the effectiveness of this one. So what's essentially happening is this one's decreased effectiveness because of this, and this one's decreased effectiveness because of this. So we set him up. That's part of the problem. He already has hyperlipidemia, so he already had high risk factors for myocardial infarction, didn't he? Because he had hyperlipidemia. That's coronary artery disease. That's another word for coronary artery disease. He already had that. Then he had an MI. And after they sent him home, these are the medicines he sent home. What's missing? Yeah, they didn't put him on an anticoagulant, which would have been a really good thing. There's something else missing, something major. The warfarin's major too, or any of the anticoagulants. But there's something else that's major here. Hey, where's his beta blocker? This man had a heart attack, and they did not send him on a beta blocker. It's like, were they out to lunch or what? Where's the anticoagulant? Why didn't they change this to an H2 receptor inhibitor and solve a lot of those problems? Yes, these two, this one is going to be somewhat decreased, but they increased the dose. So that might counteract that. But this one we can't have decreased because, and that's what this is doing. He's got to be on a statin drug. He has to be. But it does increase his risk. So because it does increase his risk, we've got to treat him with some anticoagulant. And we've got to give him a beta blocker for those circulating catecholamines. They set him up. And what happened was he went through all of these problems. Pulmonary edema and pulmonary embolism. All these problems because his meds were screwed up. And had these doctors done this to your patient, you would have helped him. Because you weren't looking at the drugs and figuring out what could go together and what couldn't go together. What learning needs did this have? Throughout this case, as the patient was coming in and things were happening, what kinds of things did we need to be teaching him? Signs to watch for. So he starts in with his MI. Comes into your ER, he has an MI. Immediately there's some learning needs there. What are they? That's right, he's a smoker, so he's got risk factors for that. So smoking cessation was a big learning need. His diet, we don't know anything about his diet. We know he's hyperlipidemia is hyperlipidemia caused mostly by bad diet? No, it's caused by genetics primarily. It's caused by genetics, and that may be something we want to teach him. Very important for him to take his statin drug, because even if he changes his diet to the point he's not eating hardly any fats at all, he's still probably going to have hyperlipidemia. And so that's not going to help him in that sense. But we do have some other modifiable things we need to assess on him. What is his diet? What is his exercise levels? Probably not while he's having that MI, but we're going to have to address those soon, afterwards. What about for the MI itself? He comes into your ER, I'm telling you, within 20 minutes, they're going to have him to a cardiac cath lab. So when that happens, we got very little time to teach anything. Where's our priorities? Okay, you come into the ER and you're having a heart attack. In 20 minutes, they're going to have you in a cardiac cath lab. What do you need to know before they send you in there? We need to teach you your drug allergies. I'm talking, what do you need to know? What do we need to teach you? About the cardiac cath, right? We need to inform him about that cardiac cath. What are we talking about? Because you know that's what they're going to say. Let's get into the cath lab. I don't know what their cath, I don't even know what a cath is. Well, it don't sound good. So we need to get that education in there quickly. That is the doctor's responsibility, because they're going to sign informed consent. But we need to go back and make sure that they understood it. If they have any questions, that we can ask them. And also what they can expect when they get out. That's a nursing responsibility, isn't it? You're going to be on that close observation. We're going to be looking at that site. You got to keep that leg straight for a period of time. You know, we've got to tell him those sort of things. So that was a big learning need that he had. Then he gets back. That's when we can start working on things like smoking cessation, learning more about his diet, his exercise, his other bad habits that he might have, you know, developing into those. That's when we can do that. When he's back from that, he's laying in that bed, he can't get up and run anyway. Might as well sit there and educate. So there's some learning needs that go along there. When they sent him home, what were some learning needs that he had? He had his MI, huh? How to take his meds and be compliant. Let's do discharge planning. What's the D stand for? Diet. So we're going to have to think about, is there any kind of alterations he needs to make to his diet? What kinds of resources does he need to be able to do that? What's the I stand for? Instructions about the disease processes. He has more than one, because didn't he have a pulmonary edema while he was in there? So he's got the new MI plus the pulmonary edema. So we've got disease processes we have to educate on, plus any new meds. The only new med, unfortunately, they did for him was increase his aspirin, but he needs to understand why. He needs to understand why now, instead of taking 81 milligrams, he's now taking 325. Unfortunately, we should have also been educating on the need for the metoprolol and changing that GERD medicine to an H2 receptor inhibitor, but we didn't do all that. So we didn't have to do those learning needs. We didn't take care of it. Then we also have to then think about the C. What's the C for? Oh, the S, discharge, S. Supplies. Supplies. Does he need any kind of supplies? Didn't give him any new prescriptions. I'm a little surprised they didn't also give him some nitroglycerin. And had they given him some legal nitroglycerin to take it home, then we would have to teach him about the use of nitroglycerin, wouldn't we? And the fact that it's got to be light protected, that if you put it under your tongue, it needs to have a little bit of tingle, that it's got a very short shelf life, so don't keep it on hand forever, get rid of it, go get a new bottle, they're cheap. Those types of things. A lot of times people think nitroglycerin will explode. You got to tell them it's not going to explode. It always does on Well Westerns, but it doesn't in a little tiny bottle of nitroglycerin. So we have some things to do with that. But otherwise, supplies, not really. But had they put him on any kinds of anticoagulants, there might have been some supplies that he needed associated with that. Who knows? Let's see, so that's the S. What's the C? Consults, things like consults. Any kind of consults that he might need, probably cardiac rehab. He'll need cardiac rehab. And that always then puts me through, if he's gonna do cardiac rehab, he may be concerned about things like activity level as soon as he gets out of the hospital. He's just had an MI, plus he had had pulmonary edema. We probably got it at least resolved, but he now has a weaker heart, plus he's now had this complication. So he may be very concerned about his activity levels, huh? We may need to talk about that. All right, so that's consults, and then H, the home. Any changes he needs to make to his home. What if his room is 2 flights up? What if he has to walk 2 flights of stairs to get to his bedroom? Can he do that right after he's had an MI? No, he can't. So now we're gonna have to talk about, can you commandeer a room on the 1st floor? Is there an elevator? Is there a way to get around this so that you're not carrying those 2 flights of stairs? And when can he walk those 2 flights of stairs? He's gonna start with rehab, and when can he expect that he'll be able to walk those 2 flights of stairs? Give me a time frame you think it might happen. Yeah, 6 weeks is a good average. Maybe sooner, maybe a little later. How will he know that he's able to walk those 2 flights of stairs? Can't be short of breath or have chest pain. That's right. Walk up a flight of stairs, and if that goes well, walk up another one. If you're not short of breath and have chest pain, it's probably okay. So home environment, that's something we need to change. That's the H. How about the next? What about the A? Appointments. Is he going to need any doctor's appointments? Yeah, he's going to need appointments with his cardiologist. And now that he has that, you got to figure out, can he pay for it and can he get there, right? Doesn't do any good to make an appointment and then you find out that the doctor lives 20 miles away and they don't have a car. Think about those kinds of things. That's the A. R, medication. So they didn't give him any prescriptions. And the G, yeah, that's the mobility stuff. The mobility stuff. And then the last one's E. Encouragement, support. Who's helping him? Where is he getting his support? Does he need to join the support group? So we're going to do all of that discharge planning stuff to make sure that we take care of his learning needs. He really should have gone on anticoagulation therapy because of the deep vein thrombosis, and he also needs to be wearing TED hose. Those are part of the guidelines, and they need to continue both of these for 3 to 6 months. Okay. Smoking cessation. Smoking cessation is a requirement by Joint Commission. All patients who tell you they smoke, you are supposed to do smoking cessation. I know it's not being done, but it is a Joint Commission requirement. And what is it? It's ask, advise, assist, and arrange. You ask the patient about his smoking habits, he tells you that he smokes 2 packs of cigarettes a day for, 40 years? 30 years. What are we over? 40 years. 2 packs of cigarettes for 40 years. So what is his pack history? I'm sorry, the number of packs per day times the number of years. So what's his pack year? 80 pack year. That's right. All that is a way to quantify so we can compare from one person to the next. It's just a way to quantify. So we're going to get his smoking habits. We're going to ask if he's ready to quit smoking and to ask for a definitive quit date. Why do we ask them if they're ready to quit smoking? What do we care? If they're not, we don't have a team member towards quit smoking. We have an opponent. If they are, we have a team member. The strategies are going to be different if you've got an opponent versus a team member. So you've always got to ask that, are you ready to quit smoking? If they say, no, I'm not ready, then you know that they're not going to be as compliant in trying to quit smoking. So we already talked about that one. We look at things like the age of initiation of smoking. Well, if he's been smoking 40 years, how old was he when he started? 19 years old. The depth of ventilation and the tar and nicotine levels, all of this is kind of the smoking habits that we want to know about. Advice: the younger a person starts smoking, the greater the risk of lung cancer. The risk of lung cancer decreases and the length of smoking cessation period increases. So if we need him to know that. If we can get you to stop, even though you've been doing it a long time, right now you don't have lung cancer, at least we don't know that you do. And if you'll stop, the longer you stop, the less likely you are that you'll develop something. You want to assist them, develop a specific plan. One of the things that always, talking about this advice, one of the things that always bothers me is the students will write on their test, or when I give a test, they'll choose on their test, I'm going to teach him how bad smoking is for him. Everybody knows how bad smoking is. What they might not know is even if they have developed symptoms associated with a smoking disorder, stopping, the longer they stop, some of those may resolve. They may not all resolve, but some of them may resolve. A lot of times they don't realize that part. So develop a specific plan and work for the client towards smoking cessation. So this patient was going to be admitted after his heart attack. So he doesn't want to stop smoking. He doesn't want to do it, but he's kind of under our control for a little bit of time, isn't he? So we can say, well, you're not going to smoke while you're here, so let's think of a plan to get you through here. And maybe they'll keep him enough days he won't want to do it when he gets out. We can do some nicotine replacement therapy, and as you look at these nicotine replacement therapies, which one do you want to give him when he came in and he was admitted? Which one are you going to do for him? The patch? Because he doesn't need to worry about his blood vessels, does he? I mean, nicotine, why do you care if they have nicotine?
Constricts.
Why can't he smoke? He constricts the blood vessels? Well, he don't need to worry about his blood vessels, does he? But you were about to put a nicotine patch on him. I got you. You're going to give him Zyban, that's right. That's the most likely one you're going to give him. Sometimes they may not do nicotine replacement at all. Because really, what are we trying to do for this guy? Is he going to go through withdrawal?
Yes.
Okay, so what's the treatment for withdrawal? Benzodiazepine. Plus, he's already got anxiety with his heart problems. Shoot, let's give him a benzo. Let's put him through withdrawal. Let's put him through rehab rather than giving more nicotine. But we're not going to give this guy this. We're not going to give that guy that, but you would have. You said, well, he needs to stop smoking, slap a nicotine patch on. That's what this course is all about. To get you to stop looking at things that it says in the book, smoking cessation, we can use nicotine patch and say, okay, but for this patient, what do I need to do? I need to think of something better than nicotine. Most likely this one, or even more likely than that, benzos. And then you're going to check with the patient, check on process. This is if they leave the hospital. Any relapses should be evaluating the patient, healthcare provider to work together. See if we can figure out what caused the relapse and see if we can regroup. We want to emphasize successes rather than failures. Actually, this process works very well for many of our habits if we would just take the process on. Are you ready for help? If the answer is no, then let me think of a plan that I can at least make some changes in what you're doing. If you won't stop smoking, will you at least, use less nicotine and tar in your cigarettes? Will you at least cut down to 1 pack a day and start on little steps for success? there's some agencies that can help these guys if they try to quit smoking. Well, that's a help for smoking cessation. But it's just so hard to do. I don't smoke, but I know it is. My husband smoked for 30-something years. My husband sold cigarettes in grade school to buy cigarettes. That's the Alabama hillbilly drug user right there. They had drugs in his school, but he sold cigarettes. He started smoking when he was 8 years old, and he sold cigarettes in grade school to buy cigarettes. I said, man, if I known that before I married you, I thought it was I married that man because he was cute and funny, I kid you not. And then there's some more websites that you have to do this PowerPoint presentation. All right, so what's the take-home message from this presentation? Don't smoke. Don't just think that things are normal. Yeah. You gotta look in. Why is this patient having so many complications? What's special about this patient that he's having so many complications? That's the kind of stuff you want to look at. All right, I am going to let you take your dosage count, but I forgot to bring the sheet. So now